Hi, everybody. I love the idea that you're sitting with your coffee and your lunch and getting some information in at the same time. I want to kind of go through with you a little bit about my passion and what I've spent most of my career doing, which is working on kind of the diagnostic end of getting people started in treatment for autism spectrum disorders. What I'm hoping that we can get out of today is a review of the DSM-V Autism Spectrum Disorder criteria. And this isn't to make you go through that criteria yet again, but mostly to give you a sense of when a diagnostician is trying to sort through whether or not someone has that disorder, the key features that are necessary in order to make the diagnosis so that you can reference those when you're making a case for medical necessity in your own reports. Another thing that I'd like to go over with you guys is what the key features of a diagnostic report are, so that when you get those in your EMR, you can quickly look through that report and know potentially where you might find something or what to expect. I also am eager to throw out a few ideas about how you as BCBAs, if you're BCBAs listening, can use that diagnostic report to inform your treatment plan. And then I'm also hopeful that this is reaching now or reaches at some point in time my fellow psychologists, because I think it's also helpful for us to know how our reports are being utilized and what are the elements that someone who's taking the baton and moving toward ABA assessment needs from us. So let me just really quickly review some things that a lot of you may already know, but it'll give us a background for our discussion here. Autism spectrum disorders are considered neurodevelopmental disorders. The important thing to remember about this distinction is that neurodevelopmental means that the disorder is related to irregular brain functioning and that it impacts multiple areas of development. So the disorder is present from birth. And then the manifestation of those irregularities is what we're trying to identify as we go through an assessment. When we're doing a diagnosis for an autism spectrum disorder, it's considered a behavioral diagnosis, which is typical of the diagnoses that psychiatrists and psychologists make. The distinction here is that we don't have a medical or physical diagnostic test for autism at this point in time. So what we're trying to do is understand a child's behavior, both currently and in the past, and identifying whether that his manifestation or her manifestation of different behavioral characteristics fits into the criteria that we, as professionals and as guided by the DSM-V, know to be the symptoms consistent with autism spectrum disorders. And again, we all understand kind of that idea of the spectrum. Part of the spectrum of autism is that symptoms range from mild to severe. But I also wanted to make the point that a spectrum isn't just a line. A spectrum is different characteristics of light bouncing off of each other. And that's true about autism spectrum disorders as well. The different constellation of symptoms can vary from person to person. So you can have mild impairments in one area to more severe in another. They manifest themselves differently depending on the level of impact that the autism spectrum process is having on your neurological functioning. So this is, and I think this is really where we get that phrase that people have heard a lot: if you've met one person with autism, you've only met one person with autism. And I also just am going to make the point in more detail, but here identify that people that get an autism spectrum disorder are also really vulnerable to having co-occurring mental, behavioral, and other physical conditions. They're complicated, it's a complicated diagnosis because it affects so many parts, not just of someone's developmental functioning, but their physical and mental health as well in many cases. Well, let me just run through really quickly what I am looking for if I have someone come in my office and I've determined that their presentation has enough concern for autism that I want to do a formal diagnosis. In essence, what I'm looking for is, does the does the child's previous history and then their current presentation meet DSM criteria for autism spectrum? For those of you that may not be familiar with the DSM, it stands for the Diagnostic and Statistical Manual. We're on our 5th edition, which came out in 2013. Excuse me. What the DSM does is it provides that list of behavioral symptoms, and it provides guidelines for how we might categorize someone in terms of a diagnostic decision. So the first characteristic here, characteristic A for an autism spectrum disorder, is that someone has persistent deficits in social communication and social interaction. And instead of breaking down all the different behaviors, I'm going to try to take a little bit of a higher level approach to what this really means. But the DSM breaks this down into 3 different categories, A1, 2, and 3. In order to meet the diagnosis, you have to have delays in each of these 3 areas. The first A1 is the idea that you have problems with social initiation. And what I want to get across here at a kind of basic level is that what we're talking about really is the building block of what we call social interactions. So when we're talking about even communication, sometimes that means language, that our kids are not verbal. But it also gets to this larger issue that communication is sort of a catch and serve type of activity. So the Harvard Child Development Center has a new sort of initiation where they're trying to coach people on early development, and they've coined this kind of catch and serve phrase to get across this essential of early development, which is a child initiates, and then the person interacting with them responds to that initiation. And the idea is that we keep that going back and forth. And so this A1 deficit is and a difficulty with a child, for example, making a request, but it's also just a broader difficulty with the child's frequency of initiation, with the quality of that initiation, and with their understanding of how to wait for and receive or catch a response, and then knowing what to do with that response. So you can have delays in this area that look like lack of requesting, I mentioned that one, all the way up to someone who can't engage in back and forth conversation. And back and forth conversation requires all these kind of subtle and higher level social skills, like understanding how to respond to a lead, or recognizing how to pick up on someone else's interests and make sure that those social initiations and responses go back and forth multiple times. In a sort of neurotypical development, once you get to be 2 years old, you're looking for an interaction that might have 50 of these catch and serve moments. And so our kids with autism spectrum disorders have much fewer, if at all. A2 really comes to this essential of, well, how do we use the nonverbal aspects of communication in order to develop our social relationships and use our interaction with people. So this really gets it. So how do we communicate if we don't speak the same language? I like to think of, I don't know how many of you still remember Sesame Street, but I like to think of those monsters that were the puppets on Sesame Street that nod to each other and point, but they're speaking kind of gibberish. But if you turned off the sound on that, you would still understand what they wanted to have happen and how they were feeling about it, because they used all the different strategies of nonverbal communication. Those can include things like gesturing, waving, nodding, pointing, but also your posture. Are you leaning in? Are you turning away? Are you slumped? The tone and rhythm and the intonation of your speech, as well as the affect that you wear on your face. Nonverbal communication just takes a lot of forms that we really don't even, we're not really even conscious of. When I ask parents about nonverbal communication, they often have to stop and think about how their child communicates nonverbally, because it's just things that we pick up sub or unconsciously. The other point that I wanted to make with nonverbal communication is that the criteria here is not just that you can engage in nonverbal communication or that you have some of those strategies, but that you're doing that fluidly and in an integrated way. So you're pointing and looking at the same time, or you're nodding your head and saying, yes, I really like that. It's being able to take multiple communication strategies and integrate them. And then A3 is this problems with social awareness and insight. And I think the basics here, the basics here are really, how does my behavior affect others and how does their behavior affect me? So what we're getting at here is basically, can you develop age-appropriate relationships and can you maintain those relationships? And this gets at a variety of things. If you kind of break down even in your own life how a relationship works, you have to understand, first you have to be motivated. So you have to understand and have interest in a relationship and take pleasure in that relationship so you're motivated to continue it. Early on in our development, we're learning how to be in the same space as other people. So for example, a developmental milestone for a child of 2 is that you're learning how to cooperate and play. You can take turns, you can give each other different objects and tolerate that. By the time you're 4, what we're looking for is, can you jump inside the other person's mind to some degree? That's a concept called theory of mind. And it means, can I anticipate what somebody else is going to do? Do I have an awareness of the fact that their experience might be different than mine? Those are things that our kids with autism spectrum disorder struggle with quite a bit. Also, part of being socially aware is being able to change your behavior based on the social cues that you're getting, whether those social cues are implicit, meaning they're communicated in someone's tone of voice, or getting back to those nonverbals, your posture, or whether they're explicit. I don't like it when you do that. Can you stop that behavior that someone doesn't like and do something different? Another thing is the ability in a relationship to have insight into when it's time for you to be the directive, sort of assertive person in the relationship, and when it's okay to take a step back and be a little bit more of a follower. A lot of our kids with autism spectrum disorders gravitate towards kids who are either younger or older than they are. And I think part of the reason for that is because they either can take a fully directive role, say with younger kids, or they can take a fully passive role, maybe with older kids. And then it helps them avoid something that they have trouble with, which is, how do I negotiate and balance both of those behaviors with a same age peer who might expect both of those things from me? The second main category that's important to keep in mind about when someone receives an autism spectrum disorder is that the second thing that needs to be present is that they have delays in what are termed restricted, repetitive patterns of behavior, interest, or activities. I know that we're all pretty familiar with what this means in terms of motor behaviors or some of our really atypical stereotypies. And this is kind of the category that they work themselves into. For example, if we're looking at B1, that gets at those atypical speech pattern movements in play. Oftentimes, as I mentioned, these are pretty evident. They look unusual, they stand out to other people because they're overt. But I think it's important too to kind of keep in mind that we're learning more and more that sometimes these atypical behaviors occur internally. So for example, I have an adult client who her play as a young child and her interests were repetitive, but they took place within the context of Bible study for her. That was what she was really interested in. And so it looked to other people like she was just fairly interested in religious topics and wanted to learn about that. But if you really pieced it out, what she was doing is looking through the Bible to find patterns and analyzing them and matching them. And this wouldn't have been something that people noticed just through casual observation for her. B2 is problems with rituals or resistance to change. I'm guessing that we're all pretty familiar too with the kids who have to have their bedtime routine happen in a certain order, or they're not able to get to sleep, or the child who is unable to move away from the TV to come eat, or gets upset when there's a substitute teacher because it's not something that he's familiar with. And I think the thing to kind of key in on here is the growing understanding that maybe one of the overarching conceptual neurofunctional deficits for kids with autism spectrum disorders is that they have a difficult time with predicting the future. There was an interesting article that some different researchers from MIT put out a few years ago, really trying to get at conceptually what are the main neurological factors that make someone with an autism spectrum disorder different from somebody else. And one of the things that they really pointed to is this difficulty being able to project themselves or project situations into the future, which makes predicting what's going to happen really difficult for them, and probably leads to the sense that routines and rituals are preferred because they offer that sense of predictability that's not there just naturally. B3 gets at your fixated interests. Again, I think if you've worked with kids on the autism spectrum, you understand that these fixated interests can go anywhere from I have to have the very same Lightning McQueen car with me at all times to you know, the older kids who've memorized the Pokemon dictionary. Taking a little bit of a step back, the way that I like to think about this, or maybe even explain it to parents, is that another sort of overarching deficit that people with autism spectrum disorders have is that tendency for the interest toward objects to potentially be stronger or stronger than normal than their interest is in people. And I'm always careful about the way they say this because I definitely believe that a lot of people, oh, excuse me, so sorry, have different, oh, sorry, you guys, I'm a little bit uncertain about how to go back. Let me figure this out. There, okay, sorry about that. What I wanted to say is that I'm careful to say that I don't think that people with autism spectrum disorders don't have interest in people or social relationships. I feel very strongly that they do, but that in some ways what's early on reinforcing in their world is their experience with objects. And so that's where their attention is focused, and that's where they are looking for engagement, or that's how they cope, or that's how they experience the world. So if you've ever heard some of the really interesting research done by people who are looking at early trajectories of eye contact, they can get even really young infants with the vulnerability toward autism whether by their own behavioral characteristics or because they have siblings that have been diagnosed. And they do these kind of really interesting mathematical trajectories of what they focus on in terms of eye contact. And they'll be looking instead of at people, at different objects around them. And I think it just kind of speaks to the fact that balance is a little bit off for this group of people. B4 is the atypical sensory behaviors. So this is getting at both hyposensitivity, which means that you're not responding appropriately to sensory input. Your response is under responsive, to hypersensitive or sensory reactions to your environment, which would mean that you are experiencing them to a heightened degree that usually causes avoidance. And I guess the larger perspective that I want to get across here is that our kids with autism spectrum disorders really have quite a different experience of the world around them. I don't know if any of you have had a chance to look online or there's some adults with ASD who have tried to make simulations, virtual simulations of what it feels like to have a sensory integration problem. And so you can kind of go on YouTube and try to experience the world like they do. And I was really shocked and surprised when I did that, how anxious it really did make me and how much I wanted to kind of get out of the overwhelming bombardment of sensory input that they were attempting to help me experience.
Natalie, I just want to prompt anyone to see if they have any questions because we're about halfway through, so I want to make sure we get through everything. Any questions so far? I'll be managing the Q&A, but I want to make sure that we are good on time. Okay, I don't see any coming through, but I just wanted to give you a time check.
Yep, thanks for that. I appreciate it.
Sure. Okay, great.
I'll just kind of go through these then pretty quickly. So symptoms must be present in early childhood, although they do sometimes manifest themselves later, especially if we think of the kids who used to be diagnosed with Asperger's. I do want to draw attention to D and make sure that this group understands that part of the diagnosis is also giving a level of symptomatology severity. So when we give a diagnosis of autism, we're going to say that they have level 1, 2, or 3. And these levels are determined based on the amount of support that someone would need in order to function in environments like homeschool or the community. So level 1 indicates that they are requiring some support. Level 2 is that they're requiring very substantial support. Another way to put this is that they would be able to communicate, but they would need some support to do that they have limited social interaction, and that their repetitive behaviors are obvious to a casual observer. Level 3 would mean that you're requiring very substantial reports, so the deficits in social communication and restricted repetitive behaviors are severe. You might have minimal response to social input, and your repetitive behaviors sort of markedly interfere with your ability to engage in the life around you. I think this is important, and I'll come back to it later, because this is one way when you're talking about medical necessity, if you can relate this to the level of severity in the diagnosis, I think it's helpful. The other thing that we need to say is that the symptoms aren't better explained by another disability. And these specifiers can also be little markers for you if you're looking through a diagnosis. If a child has intellectual impairment, and that should be specified in the diagnosis, that likely means that the impact of their autism is going to be more severe, and treatment is going to need to be more intense and probably longer. The same thing, and the same thing with language impairment. If there is language impairment, it's potentially going to mean that there's more intervention or longer intervention. Same thing when you have an additional medical or genetic condition, a neurodevelopmental, mental, or behavioral disorder, or catatonia. This is just a very brief exposure to these category severity levels. You can find this online or in the DSM, but this gives you some language about how to describe the differences or the degree of severity if a child has a 1, 2, or 3 level diagnosis. Also, I'll just move through this really quickly. Sometimes people get confused when someone comes with an evaluation because there are sort of different types of evaluation. It's most typical that you're going to see a psychological evaluation. These are going to focus on neurodevelopmental and psychiatric disorders. The psychoeducational evaluation is really looking at someone's learning abilities, both their intellectual capacity, but also as it relates to their academic achievement, to determine whether they're on grade level, whether there's unevenness between those two things. If this is done in a school setting, it's not conducted to provide a diagnosis as much as it's conducted to determine whether they qualify for access to special education services like in an IEP. And so if someone comes with a psychoeducational evaluation, it's usually not enough to get a medical treatment for autism. Developmental evaluation is going to be for younger children, just focusing on whether their development is at the expected levels. And a neuropsych evaluation is the most comprehensive type of evaluation. It's going to focus on the specific strengths and weaknesses that someone might have in terms of their brain functioning. So in this case, we're looking for not just what the problem is, but why there is a problem. For example, if someone's having trouble reading, is there difficulty reading due to a visual perceptual problem? Is it due to something like dyslexia? Is it due to a problem with fluency or something like that? The goals of any of those assessments are going to be to establish a diagnosis, to describe those functional capacities, both in terms of strengths and weaknesses, to measure treatment effects if someone isn't currently in treatment, to help the caregivers and providers understand sort of the unique constellation and makeup of a child, and then to make treatment recommendations. If you get an assessment, it's going to contain different pieces of data that's collected from an interview, from review of the records, from the tests that we've selected and administered. Importantly, there's an interpretation of all that data. There's always a written report with the test, and then there's feedback that's been given to the parents. If you get a psychological report, you're likely to see subheadings that look like this. So you're going to get their identifying information, what the referral question was, and that's going to formulate what the test is trying to provide at the end. Background information, what we did, what the results were, the summary, which would include the diagnosis, and then importantly, those recommendations. So one element that is going to be important as you look past just whether someone has an autism spectrum diagnosis or not is also whether they've been tested and given a diagnosis that we label a comorbid condition. So this means a co-occurring condition that's generally secondary to autism. This slide is just meant to kind of indicate the high level of probability that kids with autism have in terms of their susceptibility to some of these comorbid conditions. These are some of the most common. You can see in some cases from the range of percentages in the population of autism spectrum kids. For example, with ADHD, you've got a 30 to 60% possibility of having ADHD. That's a pretty big range. And I think what that's getting at is that this teasing out of a comorbid condition from the core symptoms of autism can be quite challenging. And so it's difficult to get good reads on it. The numbers here come from this reference at the bottom. But basically you can see that the rates of conditions like ADHD, anxiety, depression, obsessive compulsive disorder, bipolar disorder, psychosis, tics and Tourette's, and I find this one interesting, eating disorders, especially in the female population of ASD people, are significantly higher than they are in the general population, which is the numbers in the parentheses. So it's very common for a child to get a primary diagnosis of autism and then a secondary diagnosis in this in one of these categories. So I wanted to kind of walk through some of the ways which you might take that report that you have and translate that into the information that you need when you're crafting an ABA assessment that meets the criteria for medical necessity. So the first step in achieving a determination of medical necessity is this initial assessment that you do when a payer is first authorizing care. So this first initialization of care is that set of criteria that determines if care is needed and at what level the treatment should be authorized. So you have to make the case that the treatment is medically necessary, and then how much treatment is medically necessary. And I think here there are 4 things that you can probably lean on from the diagnostic evaluation. The first is just that DSM-V diagnosis. So when we're talking about, and when you're referencing the diagnosis, you're looking at all of the different criteria that went into making that a diagnosis. And you're looking again at that level of severity, which comes up next. I just put in here a phrase that you might want to pick up and use. If someone has an autism spectrum diagnosis, then the symptoms of the illness are active and they are resulting in substantial impairment in daily functioning. That decision has been made by the person making the diagnosis. It's part of the criteria.
Natalie, one quick question that came in is, how do you differentiate OCD from rigidity that's associated with ASD? So what are the diagnostic differences?
Yeah, that's a really tricky question, and a lot of people have a difficulty with it. It does have to do, and this is why this diagnosis is hard to make for young children, because an OCD diagnosis requires both that obsessive thought pattern that's then followed up with compulsive behaviors. And so it's difficult sometimes with younger kids to distinguish between those autism symptoms and whether or not there's kind of that obsessive compulsive link. OCD is within the category of anxiety disorders, and so it's kind of this I have to do it, or my anxiety gets so high because my obsessions are driving me. You're really trying to distinguish those two things. But part of the reason that it's been really difficult to get a occurrence rate is that those symptoms overlap so clearly.
Great, thank you.
Yeah, no problem. In terms of another thing that you can do when you're trying to make the case for initial medical necessity is, again, to reference the severity of those symptoms. So getting to the levels of symptom severity that, again, should be in that diagnosis. I gave an example here. If someone had level 2 severity status, then you might want to say something like marked deficits in social communication and restrictive and repetitive behavior require substantial support. Remember, anything on level 2 is substantial support to participate in the child's home, school, or community. Level 3, just to review, is very substantial support, and level 1 is just support. And I apologize, I am just all over the place with these, aren't I? Another thing to note when you're doing those severity of symptoms in terms of medical necessity is to indicate that the presence of a comorbid diagnosis is going to complicate their severity and is probably going to impact treatment intensity and duration. Another thing that you might want to do, and if you have a relationship with a psychologist or have an ongoing dialogue, is to make sure that the different tests that they gave and the components of their report support the payer requirements for obtaining ABA services. So in a lot of cases, payers want an autism specific test like the ADOS, or there's another one called the ADI. And sometimes you can't get treatment unless those specific tests have been completed. And so it's helpful to have some dialogue with the psychologist, or at least help the parents work through whether or not that diagnosis is going to be adequate. And the fourth thing that I think can be really helpful to get from the psychologist when you're trying to prove medical necessity is just a prescription for care. I won't go through this, but this is the one that we use here. And I highlighted a couple things that maybe the prescription should point to. One of them is this idea that neurological functioning is inadequate for the child's age, and putting the level of severity in, making the prescription clear, and making a reference to the fact that ABA is considered a medically necessary service. So the second step in medical necessity determination is whether care should be maintained at the same level. And I think this is a time when you can determine whether it makes sense to refer a child for a reevaluation. A reevaluation can support things like the identification of comorbid diagnoses that may not have been identifiable when a child was young. They can give you a wider variety of data about how that child's functioning compares to the normative population. So the tests that the psychologists give are going to be normed, meaning that they can let you know more clearly how that child is doing in comparison with neurotypical children, and how far behind or how much they've gained in comparison to that population. They can also speak to response to treatment by comparing initial data that they collected with what's happened over the course of treatment. And they can talk, I think, to the family's acclimation to what can be a life-changing type of treatment. ABA is intensive and very parent and family oriented and challenging sometimes, I think, for parents. And so I think at some level, a reevaluation can also be a time for them to sit down and talk through both the positive and potentially the barriers that they're feeling as a family to treatment. And it can be a time for the psychologist to really support during that process of testing and feedback what areas have benefited from their commitment to treatment and what areas probably still need some investment on their part. When to refer for reevaluation, I think some of the things that you might want to keep in mind are if a child isn't making the expected progress. It might be a good time to have them reevaluated to see if we can determine any reasons for that might be neuropsychological or related to their mental health or other medical conditions. If you're identifying new symptoms or symptoms are becoming more prominent, and sometimes that happens as children develop and also as they're exposed to different contexts and settings, and that gives us a chance to look a little bit more into what's the unique profile of that child. If a child has been tested when they're young, which is what we hope when there's an autism spectrum disorder at play, it is often really important to have them reevaluated when they're older, because they can participate in more thorough testing, and usually the test results become more valid as a child reaches the ages of 6, 7, and 8, especially when we're talking about some of those neuropsychological tests or intellectual testing. I also like to talk with our therapists about having a child tested during any kind of transition period. So if they're moving from early intervention care, for example, into kind of more of a preschool setting, or if they're moving from a preschool or kindergarten setting into a full day of school, I think it's helpful for us to have the data that helps both the ABA team, but also the parents understand how they might respond to the new challenges of their of the setting that they're moving into. And then I think if you feel like there are different, like additional data is needed to determine the level of care and to bolster the case for ongoing care at the current level, the comprehensiveness of a full evaluation can help with that. So the third step in medical necessity, which begins even when you're creating your treatment plan initially, is that sense of when do we know when termination of care needs to happen, and how do we determine whether a change in care needs to happen. And I think what I wanted to point out here from the side of a psychological report is some of those decisions can be impacted by a few things. Intellectual functioning is an important one. And I'm going to go through a little bit more in detail, maybe how to read a report around intellectual functioning. But there is a high percentage of kids with autism spectrum disorders that have some type of intellectual delay, meaning that their overall level of cognition, problem solving, ability to engage in abstract reasoning is lower. And that they also have deficits in terms of their adaptive abilities, so that they're not able to function at the same level of independence as we would expect for someone of their chronological age. If a child with ASD also has deficits in intellectual functioning, I think that this impacts both the rate of progress, but it also should be taken into account when you're talking about a FADE plan. So by the time we're able to identify clearly that someone has an intellectual delay that is going to at some point impact their ability to continue to add new skills, at least at the same pace that they might have when they were younger, and definitely not at the pace that someone of their same chronological but different mental age could do, then the FADE plan or the termination plan starts to center around things like getting to the highest level of independence that someone is capable of, determining how to help them with those kind of functions of daily living, and also how do we help them meaningfully engage socially and otherwise in terms of contributions in jobs, etc., for their lifespan. I think when we're talking too about changes in care or FADE plans, it's helpful to take into account specific developmental disabilities. So for example, if someone had something like apraxia, which is a deficit of expressive language that's related to the neurological connection between language production and your oral motor skills, that person's language is probably always going to be delayed over and above what you would expect for the developmental delays associated with autism. And so even as you're fading out of services because they found alternate ways to communicate, they might continue to need a high degree of an intensive therapy around speech issues, or they may continue to need those kind of assistive technology supports in that one particular area, even as other areas, for example, social development, might be reaching the level of need to fade. If someone has a significant mental health or psychiatric diagnosis, then another thing to think about just in terms of their care and their changes in their care are that people, especially with significant mental health problems, are likely going to be coming in and out of higher levels of care, such as day treatment or residential treatment, and then potentially re-engaging in ABA therapy. And I think that transition about how to determine when higher levels of care are needed, how to transition back and forth between those levels of care, that usually requires an extra level of coordination with some of those other community supports, as well as with the other treating providers, in particular that psychiatrist, because medication usually becomes a fairly prominent part of that person's treatment.
Natalie, a couple questions coming in.
Yeah.
One of them is, what are your thoughts regarding connecting adaptive self-care deficits to an ASD diagnosis? Many funders deny treatment for these deficits because they're not social or communication deficits.
So they're saying that they're not related to the core symptoms of autism.
Correct.
Yeah, I mean, I think in general, what we're looking for in one of the characteristics or one of the criteria for autism is that it impacts your functioning across areas. And so if you're looking at something like, let's take like activities of daily living or chores. So it might not be clear, it might not occur to people that they're clearly related to those social communications or repetitive deficits. But if you can make the connection a little bit more clearly, you can say, hey, if this person isn't able to engage with the family and the family activities at some level, then they're not engaging socially. Or if their repetitive behaviors are keeping them from doing that, it's going to impact their ability to access that social environment that they need to be in.
Okay, great. And then one other question is, where should I look for information on how to determine what an individual's highest level of independent functioning might be when determining fading criteria?
So a good place, and I'll actually kind of get here a little bit. I wanted to just give an overview of intellectual disability. So when you're looking at intellectual disability, there are also levels of severity that go from mild to profound. And the way that the DSM works now is similar to the way it works for autism, in that these levels of severity are based on their ability to independently manage their life. So the same table that I had showed and that speaks to what you would expect for someone that had a level of severity of 2 with autism. The same table exists for people with intellectual disabilities. And I don't have it here. I can definitely get it to you, Sarah. But what it looks like is it would say, hey, someone with moderate intellectual disability would be expected to have a lifestyle that included these types of activities. And you can translate that into some of the assessments that you're doing, whether it's the AFLs or the Vineland or something like that, by looking at not their chronological age, but their mental age. So you would say, and I can also give you the formula for that, I don't have it here, but IQ mental age would mean this is the level of mental ability that you'd expect of someone who had this particular chronological age. And so that's what you might use when you're looking at, when you're trying to interpret something like the Vineland, and then using that as your criteria for fade. Hey, if they get to the behaviors that would be associated with someone of a chronological age of, let's say 8, even though their own chronological age is different, that's what we're shooting for.
Great. And then the last question that I have here is that I've seen organizations have difficulty with funding due to the classification of neurodevelopmental versus mental health. Can you touch on that at some point if it fits in?
Yeah, so that's getting at the question whether an autism spectrum disorder is considered a neurodevelopmental or a mental health issue. And I think what we get into there is sort of that mental health parity, where we're saying the best treatment for an autism spectrum disorder, the medically necessary treatment, is ABA. And even though it falls within sort of the mental health category from the DSM, the treatment for it is under the auspices of medical treatment and supported by the mental health parity laws.
Great, thank you.
I'm going to just
about 5 minutes left, so if you have
yeah, I'm just going to kind of move forward.
Yeah, keep on going, and as they come in, I'll ask you too if you want to wrap up.
Okay. So just really quick, I had thought through some of the things that if we have comorbid conditions, some of the ABA programming techniques that might be helpful to think through. So for example, if we have someone with ADHD, we found it's helpful to think about shaping, because you can't keep someone, you might want to help someone move through learning a series of tasks in a more way that allows them to practice and maintain attention over time. And you're really also looking at environmental modification, right? Where you're really looking at, hey, we don't want too many distractions in the environment. I also wanted to say a few things about executive functioning. So executive functioning addresses these kind of neurocognitive issues like planning and shifting and working memory. And I think that part of what I wanted to get across about executive functioning is that they're really getting at this ability to cognitively and behaviorally manage multiple pieces of information at once. And so a lot of the useful ABA techniques like visual supports, time delay, scripting, or social narrative, they're ways of helping break down that information and keep people both learning how to learn a routine so they can go from one thing to the next simultaneously, how to generalize. And then the other thing that I just wanted to bring up about executive functioning deficits is that they, until they're identified, they may be impacting behavior problems and you don't even know it, because kids with executive functioning deficits definitely have to make more of an effort to get through their day. And then I wanted to just kind of really quickly do a shout out to my psychology friends and just encourage them to write their reports in a way that can be helpful to our ABA treatment counterparts. One thing that I think that we could do that's helpful is just really specify all the diagnostic criteria. I think that we need to document the position that therapy is going to make functional gains beyond those expected as just a result of growth and maturation, and make that clear. I think it's helpful and incumbent on us to know what the payer requirements are for that evaluation. Oh my goodness, I did it again. I think it's also super helpful. A lot of times psychologists give just a rundown of recommendations, and I think that it's really helpful for other people, treatment providers, if we can prioritize those and if we can make them behaviorally specific. I think that it's really helpful to provide information about how you would like ABA providers to reach out and collaborate with you, and to make yourself open and available for that. Once a family has established a relationship with a provider, whether it's on the ABA side or as a psychologist, it's usually helpful to return to that person so that they can look at the child's progress over time. And if you can be involved and available to their ongoing treatment providers, that collaboration is just tighter and more effective. And then I think that just recognize as psychologists that early treatment depends on getting that report done and turned in. They can't get treatment done or started until we get our reports in, and so even a lag of a couple months can mean a lot for a young child.
Thank you so much, Natalie.
Right. Yeah, sorry I had to rush through the end there, but
we have one more question pending that hopefully we can get in, since we're right on time, so maybe you can make this quick. But the question that I have pending here is that I've seen organizations have continuous debates on how many hours to recommend for ABA therapy after an FBA has been completed, and do you have any general rules of thumb?
So, I mean, typically the general rules of thumbs, and I'm kind of quoting the BACB here, are that if you are looking at a young child who has deficits in multiple areas of development, then you want to make recommendations for fairly intensive treatment, 25 to 40 hours. And if you're looking at someone who is either a school age, so they're ostensibly getting treatment elsewhere in their educational system, but only has a few goals that they're really focused on, then you're looking at maybe between 15 plus. But in a lot of ways, again, those different severity specifiers, the levels, the comorbid diagnoses, and to some degree when they get started with treatment, all factor into that as well.
Great. Well, thank you so much, Natalie. This was incredibly informative and an important topic for all of us to listen to today. I know I greatly appreciated and learned a lot. So thank you for joining us. For those of you who are still with us, we will see you next month for our next webinar, and we'll be in touch about the CEUs. If you got them, feel free to reach out if for some reason you don't. Thank you and have a wonderful rest of your Wednesday.
Thanks.